Okay, this is our EBP presentation.
Spastic dysarthria is a motor speech disorder that is caused by a bilateral damage to the central nervous system. It can affect the phonation, respiratory system, articulation, and resonance systems, including individuals with spastic dysarthria have weakened muscular control, which affects their speech patterns and speech intelligibility in which they communicate and receive messages. So some common features are increased muscle tones and spasticity, sets it apart from other dysarthrias, harshness in voice, strained voice, pitch breaks in voice, slow rate of speech. It occurs when there has been a brain damage to the pyramidal and the extrapyramidal tracts.
Amyotrophic lateral sclerosis or ALS is a neurodegenerative disorder affecting primarily the motor system, resulting in damage to either the upper motor neurons or the lower motor neurons. And it can be classified with spastic dysarthria or flaccid dysarthria, depending on which neurons are damaged first, and then the symptoms will vary. There are two types of ALS, and they are bulbar onset and spinal onset. The bulbar onset has symptoms of spastic dysarthria, hyperactive gag reflexes, facial and oral weakness, and dysphagia, while spinal onset has upper motor neurons involved, weakness, spasticity, and painful cramps in the extremities, and increased reflexes. Primary characteristics are imprecise articulation and changes in mood or pseudobulbar effect. Another uncommon characteristic is jaw clonus, which is commonly associated with jaw clicks.
So the first behavioral treatment we decided to do is the combined respiratory muscle training, CRMT. The goal of this is to strengthen the inspiratory and expiratory muscles to help with fatigue, lung volume, voice clarity, and respiratory strength in patients with dysarthria. The implementation of this treatment is using diaphragmatic breathing. Patients were instructed to correct their posture to sit upright during this and firstly inhale, then exhale through the device called the breather. If patients were unable to have a tight seal, they were allowed a face mask or a nose clip as well. Some aspects of this is that the settings were on the device were individualized to each patient due to their abilities. And this is a 4-week process, 1 session per week that was supervised by the therapist 3 times a day. And then the patient had to practice outside of supervised therapy times.
The second behavioral treatment we chose is the Lee-Silverman voice treatment, also called LSVT loud. The goal of the treatment is to increase voice loudness. By increasing loudness, articulation, vocal quality, rate of speech, and intonation improve. They also have increased sensory recognition for their loudness level and have increased ability to self-cue. It's implemented by performing multiple tasks, including maximum sustained movements, which are 15 reps of ah in a loud voice quality for as long as possible. Directional movements, which are 15 reps of ah in a loud voice quality going up in pitch, and then 15 going lower in pitch. And functional phrases. So the patient states 10 phrases he or she says in daily functional living and performs 5 reps of the list of 10 phrases. The aspects of this include an increased motor output, high intensity, 4 consecutive sessions per week for 4 weeks, high repetition, at least 15 reps of each exercise in sessions and in homework, and individualized at-home assignments.
We have decided to go with a combined respiratory muscle training for our treatment plan. This is a method that has been used for multiple types of dysarthria, which shows that it is an adaptable approach. It is based on the idea that breath support impacts overall speech intelligibility. This study was done, that I read was done with similar treatment parameters as noted in the previous slide. There are multiple improvements that have been noted. The first is an increase in peak flow inspiration compared to the control group. The second is an increase in self-reported speech intelligibility. And the last is the average word level intelligibility was also increased. There was a noted greater improvement in self-reported speech intelligibility compared to the single word level intelligibility, which is likely due to the lack of contextual cues that is had at the single word level.
Speech language pathologists play a role in family and client arguments. Speech language pathologists provide 2 types of counseling: informational counseling, which informs the client and family or caregivers about the type of disorder, possible treatment, prognosis, and available resources. The second type of counseling is personal adjustment counseling. This counseling involves the SLP acknowledging and discussing the patient's and family caregivers' feelings and concerns about the disorder. It is important that the SLP recognizes what care is within their scope of practice and when to refer to another professional like a psychologist. Some of the ASHA Code of Ethics that relate to it are Principle 1, Rule B, Principle 2, Rule A, and Principle 4, Rule A. And now these are our references.